just taking a look at all of those statistics that Harris was just showing us, and we all know that behind all of those statistics are really tragic personal stories. And as we become aware of that, the urgency that we all end up feeling about how we need to address this problem, both from heroin and prescription drugs, and how it needs to be addressed immediately. A lot of times we start getting really impatient with ourselves, and we start feeling like, why aren't we there yet? Oh, that's the title of our day. And that's actually why we chose that title, because it can be really frustrating. And we know it's especially frustrating for those people and the families that have actually experienced this and are going, where are the solutions? So what I'm actually hoping to do with this little presentation here is to try to give us some context and add a little bit of insight into this, the whole thing of why we aren't there yet. Yeah, just so that we can, I'm thinking about what the commissioner said at the very beginning, reminding ourselves that this is a sustained long-term effort. It's not going to be solved with one summit or even two summits. It's not going to be solved in summits. It's solved in the work that's in between. And the work that's in between is actually, we use a framework that's called collective impact. Now, actually, this is what the inside of my brain looks like most of the time. I don't know how many of you share this, but it's just, after a while, it just is all pretty overwhelming. And that's because this problem is one of those that we now call messy problems or wicked problems. These are problems that have so many different contributing factors. They have so many different ways that they can be solved. They're not really simple. And here's a better look at what a social mess actually looks like. And I really love this slide because I can relate to so many pieces of it. But there's no one correct way to solve the problem. There's a lot of different intervention points. There's numerous constraints, ideological, political, economic. A lot of times it doesn't seem very logical. It's like 1 + 2 = 7. I mean, it's not a linear process. And through all of it, there's a really great resistance to change. Another way of looking at this, I really like the way that John Kania describes the different types of problems. A simple problem is baking a cake. So as long as you've got the recipe and you kind of do it, and you'll pretty much come out with more or less the same results every time. A complicated problem would be sending a rocket to the moon. So you've got a formula that you need to follow very, very exactly, or you're going to have really disastrous results. But if you do that same formula, you'll pretty much get the same result. A complex problem, and I think the example here is perfect, raising a child. Because there is no recipe. Those of you who have ever been involved in raising children or watching them be raised, you can even have, more than one child in the same family. There's no recipe. You could do the same thing. It's going to be different. And that has to do with all of the other factors that are involved. And I don't know, calling raising a child a messy problem, I guess there's more than one way you can look at it. So we know that despite all of the talk and the attention that's been given to addictions and the problem of opioid overdose, there's clearly something not working in New Mexico, or we wouldn't have the problem that we have. So we can see how easy it is to fall into the traditional approaches to solving our problems. The funders will fund individual grantees. The organizations work separately and they compete with each other. Evaluations very often are attempting to find the one thing that made a difference, only one thing, and they discount everything else. Change is assumed to depend on just scaling up an organization by itself. And corporate and government sectors are often disconnected from foundations and nonprofits, often disconnected from each other. Everybody's disconnected from each other. This is where that whole concept of silos comes into play. So if we imagine a different approach that actually looks like this, there we go. Isolated impact is what we call it, what we have right now, where we do have impact. We have different organizations and institutions that have really excellent programs that have an isolated impact on a certain small number of people. But what we really need to get to is that bottom one, the collective impact, and everybody aligned and working together is really the only way that we're going to solve the problem at a population level. Otherwise, we're only solving little pockets of the problem. So I like the very concise description here of the kind of mindset change that we have to go through. In the old way, it was technical problem solving. Now it's adaptive problem solving. I think we did some adaptive problem solving maybe here this morning. The old way, it's who gets the credit. And in the new way, it's who has the credibility. And I really want you to let that sink in because it's super key to the work that we're doing. And in the old way, you're looking for the silver bullet. What's the one thing that's going to make a difference? In the new way, it's the silver buckshot, because we know that we've got to come at it from all different angles. What it takes in order to really have a collective impact, achieve a perpetual state of simultaneous planning and doing. As a trained planner, actually, I really like this because there's no such thing as you have a plan first and then you go and do it. You're doing it all at the same time. Allow for the shock of the possible. If you think about how often we make excuses for why something isn't possible, so we need to allow for the shock that actually it may be possible and let it happen. Paying attention to relationships, I'm sure you've all heard this. That's at the base of everything that we do, is the relationships that we develop with each other. Listening for how to respond to unanticipated results, because it's not going to come out the way we had it in our strategic plan, and we have to really pay attention and grab a hold of those opportunities, and then adopting an attitude of burning patience. And I think that's a lot of what this is about. We have to have patience with the process, but it has to continue to have the fire underneath it. So there's 5 conditions that they talk about in collective impact. The common agenda for us is reducing opioid overdose deaths. That's like a centralized point that we work towards together. The shared measurement, we're learning as we gather the data that everybody has different definitions and different measures of everything, and it starts getting really hard. I know Harris has had a lot of frustration as he goes through this thing because you find out this place measures it different from that one, et cetera. That's something that we have to work towards. The mutually reinforcing activities, all the participants, everybody here has a special area of focus, and that's okay, but because everybody doesn't have to do everything. We're not asking for that. But all these different activities have to be aligned and linked and mutually reinforce each other. Communication's always important, but it's not something that you just do once and it's done. It has to be continual. And the issue of a backbone support, that is really essential to making collective impact approach work. Otherwise, it just dissolves into one of those collaborations that I think we've all been through, where it just kind of, you come together and then nothing happens and then it fades away and then you find yourself in a similar meeting a couple of years later and think, wait a minute, I think I've done this before. So part of the key to keeping it going is having this backbone support. The backbone support needs to be neutral. It has to be a separate entity or some kind of an organization that that isn't necessarily one that's doing the stuff, because that's how you can develop trust. You have to have that neutrality. Now, this actually, the important thing for us to think about right at this point that we're at is that collective impact, there's 3 different phases that they identify. So phase 1, initiating action, is the planning period. And we're still kind of in the planning period. There's a lot of things that we're still involved in terms of putting it together. At the same time, that we've also got a foot in phase 2 in organizing for impact, because we've got activities that are already being undertaken. So right now, where we're at in this stage is kind of in between phase 1 and phase 2, going back and forth. Phase 3, the sustained action and impact, that's where you actually see the population results, and you see the change, what they call it, turning the curve on these things. So this is actually to kind of help us, when you see this laid out, and think about the early years, the middle years, and the late years. We're still in the early years, kind of going into the middle years. So our expectations of ourselves, of why aren't we there yet? This is why, is because we still have a lot of work. This is the way the process works. We have to do this. One of the things in this slide, I think that's very key, hopefully it shows up there, it's very light. Number 1 says social, political, economic context. And if you'll notice, everything is kind of framed in that. The things that are happening around us, in the city, in the state, in the whole country, in the world, that whole context is something that's going to be affecting everything that we do all the time. Number 2 there shows that structure in terms of the common agenda, the backbone, et cetera, et cetera. When you get to number 3 with my type is really small. With the outcomes and indicators, the intermediate outcomes, there we go. Those are the ones that we're actually, like I said, we're starting to move into a little bit. But number 4 is that bigger impact. So this is just to kind of give people a sense of where we are, so that we don't get way too impatient with ourselves. And this is just to finish up here, this is a slide that shows what our structure currently looks like. This is what grew out of the first summit that we had. The 4 implementation teams that you're going to be hearing from later today, and each of those has co-chairs that goes to that participates in the coordinating committee, and the coordinating committee helps with then takes that information and helps to plan these events when we all come back together. But then we go back and we're working in our teams. One of the reasons why I wanted to show you this, and there's a description there of kind of what we do, but one of the reasons I want to show you that is to go back to what Bill was pointing out in the packet in terms of the commitment form. As you hear about the different reports back, you can be thinking about how this all fits into our structure and if there's a place where you think you might be able to contribute. So this is actually really an opportunity for us to try to bring more people in to the circle. So I'm going to go ahead and, whoop. That's interesting. Okay. Just go ahead and stop there. But I did want you all to kind of get that context. We have the data, we have the process, and we're going to be starting to move now into the content. So thank you very much.
Hello again. So I have the great pleasure of introducing Dr. Tim Condon. Dr. Condon is a nationally and internationally recognized neuroscientist, and I'm going to tell you why we are very blessed to have him. He's a research professor currently at the UNM Center on Alcoholism, Substance Abuse, and Addictions, also known as CASA. I'd say Dr. Condon has done more than anyone else out there to reduce the stigma of the disease of addiction. Dr. Condon, prior to joining CASA, served in the White House Office of National Drug Control Policy as the Science Policy Advisor to the Director. Before going to that Office of National Drug Control Policy, Dr. Condon was Deputy Director of the National Institute of the National Institute on Drug Abuse of the National Institutes of Health. And I'd like to introduce Dr. Condon so he can give his talk, Addiction as a Brain Disease Beyond a Reasonable Doubt. Thanks.
Well, thank you, Harris. Good morning, Bernalillo County. Okay, that's better. The coffee's kicking in. That's great. That's our drug of choice. I want to thank the commissioner for inviting me to do this. We met about 3 or 4 years ago, actually at a county commission meeting, when there was talk about eliminating the methadone maintenance program at the MDC. I certainly want to thank my colleagues, Marcia, Bill, and Harris for all the work that they've done, and working with them over the years has been great. I'm a neuroscientist by training, and as you heard from my brief bio there, I used to work at 50,000 feet on drug policy. I live in New Mexico now, and I work on the ground where the boots are. It's a very different perspective. But I'm still going to tell you a lot about what science has shown us in the last 20 years about drug abuse and addiction. Advances in science and technology have revolutionized our whole way of life. Not just about drug abuse and addiction, but our whole way of life. Think about it. So does anybody remember this? I'm going to date myself. This was Lieutenant Uhura. And what year was this popular? 1968-69, that's exactly when it was. I was a Trekker, and I watched this, and this was back then, 1969, science fiction. But it wasn't recent, not even recently, but in the last 10 years, in fact, we found that this changes in our technology, advances in science, made this a reality. Anybody remember this? This is the first computer. I'm old enough to remember this. And that was an IBM computer back then. And of course, technology has just changed the way we look at things and how we work. So advances in science has revolutionized, and technology have revolutionized our whole life, but they've also revolutionized our fundamental understanding of drug abuse and addiction. 60 years ago, it was a moral fiber disease, weak-willed people, bad parents, pull yourself up by your bootstraps. We know now, because of the neuroscience that's been supported over the last 20 years, that in fact, addiction is not just a social problem. There are incredible social elements to it. It is in fact a biological problem as well. It's a medical problem. 30 years ago, the term addiction medicine was an oxymoron. It was all in the world of social work. But now I tell you, addiction medicine and the American Board on Addiction Medicine is training thousands of physicians in addiction medicine and addiction psychiatry. So it is a medical condition in addition to being all those other things. So anybody remember this? Okay, what year was this popular? 84? Before that? Well, you know, we don't have a lot of humor in drug addiction research, but we always used to say that somebody would say this is from the 60s, and we'd always say, if you remember the 60s, you weren't there. And so that's really one of the only jokes I'm going to tell today. This is actually from 1987. It was our good friends at Partnership for Drug-Free America, and this is the way we depicted your brain on drugs in 1987. Egg in the frying pan, people made fun of it, but in fact, it really got into our local jargon. It actually it became folklore, even though people didn't like it and made fun of it. I used to see it on T-shirts at the beach. This is your brain on drugs, and have this picture, and you turn around and say, this is your brain on drugs with a side of bacon. I mean, this really got into our culture. And in fact, in 1987, this is the way we needed to depict your brain on drugs. But voila, in a very short few years in the early 90s, neuroimaging actually came along to the field of addiction. And it revolutionized how we started to see people's brain on drugs. So this is from 1999, but as early as the early 90s, neuroimaging, and this is an MRI, actually could look at real-time people's brains on drugs. And so what we have here is the yellow and the red are activation areas. And in the middle panel, I'll tell you that the NAC, the nucleus accumbens, is really the business part of the reward reinforcing pathways of the brain. You love these areas to light up like that. That's part of the euphoria and the high associated with drugs of abuse. And you can see the same person got a saline solution down below. So the cocaine just made these areas light up like a Christmas tree. And again, that's, we believe, part of the euphoria and the high that people get and the reinforcing from drugs of abuse. So what have we learned? Drug abuse is a preventable behavior. These are two simple sentences, but they surround the complexity of the whole issue. But drug addiction is a treatable disease. We can do lots of things to help prevent people from taking drugs in the first place, especially our young people. We're really kind of not doing as good a job with that as we should be. And that's not just here in New Mexico, that's throughout the whole country. Prevention has kind of fallen off and that is why we're facing wave after wave, whether it be ecstasy. I mean, let's see, when I was at the National Institute of Drug Abuse, I went through the cocaine epidemic, the ecstasy epidemic, the methamphetamine, and then the prescription drugs. So all of these things, you know, we can actually do things to prevent them, and so we're not really doing a very good job. But once people become addicted to a drug, I believe that their brain has changed, that they're in a different state, and they're no longer able to just, you know, stop using drugs. And we have to treat this as a disease. So why do people take drugs in the first place? Well, there are lots of risk factors the research over the years has identified as to why people take drugs in the first place. The community. What is the community norm? That's a big deal here in New Mexico. In communities, it is normal in some places for whole communities and families to be taking drugs. Peer clusters, very important also. We know that about our schools, who our kids hang around with. Family, parental modeling for substance abuse is the #1 risk factor there is. Parental modeling, parents using drugs in front of their kids is the #1 risk factor. And I'm sad to say we have that everywhere, not just here in New Mexico, but we have it everywhere. And the last one is the individual. And that's where some of the biology comes in, because we now know that everybody in this room, I'm not sure about you, Harris, but everybody else in this room's neurochemistry is different. You know, you all have different genes, you all have different genomes, and the amount and number of neurotransmitters and the kinds and the areas, all of these are different in every individual. So every individual is going to have a different either resiliency or vulnerability to drugs of abuse, because everybody's different. Why do people take drugs? Well, I like to boil this down to two areas. One is to feel good. This is people feeling who want to get high, who do this for the experience, who share it with friends, who do it as a community, and it's a really reinforcing thing. And this is true. This is what drugs do. They make people feel different. But there's also a whole another group of people that we don't pay enough attention to. And these are people who are taking drugs not to feel high, but to feel better or normal. These are people who suffer from some anxiety disorder, depression, other kinds of mental illness. They may be hopeless. In fact, they may be in despair because of their lives have gone so out of control. They take drugs to get through the night. So if I show you these PET scans or these brain scans of what drugs do to your brain, I'm going to show them to you in a minute. I show that to someone who's in crisis and trying to make it to tomorrow morning, it's going to have no meaning. If I show it to some of the people who are just taking it to get high and say, maybe, you know, you could do what we used to, I'm going to date myself, we used to say, go do bungee jumping, but what's it now? Zip lines, right? You can get the same kind of rush from that as you can from drugs of abuse. So we have two different groups, and we have to pay attention to where people are in that group. And if you look at the bottom of the second group, withdrawal, How many times have I met somebody who's a drug addict who says, you know, doc, I don't get high from the drugs anymore. I'm just taking it so I don't get sick. And that's especially true for alcohol and for opiate addiction. I don't even get a buzz anymore, but I'm so afraid of withdrawal. And so it's not to say also that the people who are in this group don't end up in this group as well. And so that's where we have to do major interventions. So a major reason people take drugs is because they like what it does to their brain. So it's a very complex interaction. It's the drugs themselves, the brain mechanisms, the environment is important, the behavior is important. We have to retrain people's behavior. But it's not just the drugs and the brain mechanisms. It's a very complex behavioral and neurobiological disorder that has all of these components. And Marcia, you said it very perfectly, that this is a messy, complex issue. And the solution is also messy and complex. So what did we learn about vulnerability? Well, we don't know everything about vulnerability. As I said, everybody's neurochemistry is different in this room. Everybody has a different risk factor or resiliency factor for drugs of abuse. But we know that's because the genetics interact. There's a huge genetic component here. And the interaction of this contribution is extremely complex. So we haven't teased it all out yet. But we do know that the environment and the genes do interact with the individual's biology, and you end up with whatever the person's behavior is. So between 30 to 60% of drug abusers have a concurrent mental health diagnosis, including personality disorder, major depression, schizophrenia, and bipolar. In the criminal justice settings, where I do some of my work, that number's higher than 60%. It's probably up to 85. And we have, in fact, used our criminal justice facilities to warehouse people with mental illness and addiction. And that's one of the things about 10 years ago I decided, a neuroscientist, I like the brain stuff, but you know, the biggest impact we're going to have on this issue is to work in the criminal justice settings and get people to understand they're not just bad people. Some of the people in jail and prisons are bad people, and I want them there. But a lot of the people there have mental illness and have addiction, and it's something we can solve. It's something we need to solve. It's the right thing to do. So initially, drug use is a voluntary behavior. A person chooses to take drugs for the first time. That's right. Everybody chooses. You don't have to. In some cases, people are forced, but it's a voluntary thing in most cases. Initially, a person takes drugs hoping to change their mood, their perception, their emotional translation to change their brain. So now I'm going to geek you out a little with my neuroscience slides, and they're really pretty simplistic. The dopamine system is the key component in the reward or the reinforcing properties of the brain. All drugs of abuse work on different receptors in different parts of your brain, but at the end of the day, they all work to increase dopamine. Dopamine release is what happens under natural reward systems. Natural reward systems, the brain is wired up so that natural rewards are reinforcing. Think about it. Food and sex, food and sex, food and sex. If those two things weren't reinforcing and wanted to make you do them again, we wouldn't be here as a species. So the brain is wired so that these natural reinforcers, perpetuate the species. And dopamine is one of the key components of that. And as I said, the nucleus accumbens is the business part of that. And I'm usually, when I have a little bit more time, I focus the microscope down and we talk about the neurons, but I'm not going to do that here. So the dopamine system is involved in reward, motivation, pleasure, euphoria, motor function, and compulsion. And these are very important functions, and yet drugs of abuse all impact and change this system. Did it change? No. So I boil it down. This is this is actually a little dated now because there's a lot more sophistication to this neuro model of the circuits involved in drug addiction. But think of it, these are all involved. In the red, we have the reward system that I just showed you, the dopamine system, the nucleus accumbens, the striatum, all these sorts of things. Learning and memory in the purple, the amygdala and the hippocampus. These are incredibly important in drug addiction. They're important in our everyday lives, but they're also incredibly important in drug addiction. Motivation and drive. What motivates you to get out of bed in the morning? Most people get out of bed and they're motivated because they love their family and their jobs and their communities, but that changes when you become a drug addict. It's not that they still don't love their family, it's not that they still don't love their community, it's that drugs have replaced it as the #1 priority. And there's a reason for that, I'm going to show you a little bit. And then there's inhibitory control. And this is kind of the newest areas that we've been doing research on. This is the area in the prefrontal cortex of your brain. And this is the area responsible for judgment, executive function, for decision making, for weighing the risks and the benefits of things. And we call it the inhibitory control because, think about it. I want to do something, but I know it's not good. And I always give myself as an example. I do public speaking a lot, travel around the country, and check into a hotel late at night and get into the bed, and all of a sudden, the M&Ms are calling me from the minibar. I have an M&M problem. I don't need any more M&Ms. It's bad for my organism. And I say that, oh no, I'm not gonna have them tonight. And but I remembered how good they were the last time I had them. And what's my motivation? I only have to get out of bed and go over to the minibar. That's not such a big deal. And my inhibitory control is fighting and fighting and fighting. And so I'm happy to tell you, even though I was in a hotel last night here in Albuquerque, because I live in Santa Fe, I did not have the M&Ms, because there are none in the mini bars in the hotel. So availability and access is a huge issue when it comes to drugs of abuse or anything else. And now, I tell this story to make fun of myself, but so that you can all relate about, yeah, I really want to do something, but I know I shouldn't. I really should want to eat something, or I really want to do this or that. And I had a recovering heroin addict come up to me one time, and he was mad after my talk. He was mad. He said, how dare you compare your M&M issue with my heroin addiction? I said, well, I didn't say I was addicted to M&Ms. He said, that's right, you're not addicted to the M&Ms, because if you were addicted to M&Ms, you'd be packing them in your suitcase. He was right. And I apologized to him, said I didn't mean to make light of your horrible experience of being addicted to heroin. And so I never say I'm addicted to M&Ms, I always say I have a problem. But that brings it down to a level that we can all understand. So prolonged drug use, we know that the acute effect, we like the dopamine to go up. We like all those areas of the brain to light up when we initially take drugs. But over a prolonged period of time, drug use changes the brain in long-lasting and fundamental ways. And what does that mean? Well, you don't get as much high. Think about things like tolerance. The same amount of drug that you took the last time doesn't give you the same effect. Why is that? It's because the brain is changing as a result of the exposure of those drugs. Here's an example of what a long-lasting and fundamental change, because people always ask me, is it permanent brain damage? And I never use that terminology except for things like inhalants, which actually do cause permanent brain damage, and people who use stimulants who get strokes, cerebral cardiovascular effects. Those are damaging things. But does it damage it? Other drugs damage your brain? Well, we don't have all the data for that, so I don't say that. I say, though, that these are really big changes that occur in your brain after prolonged drug use. Here's an example. This is work, and I'm sorry, I left off the references. I don't know how it got left off in this set. This is work by Nora Volkoff, who's the current director of NIDA, and at the time she was the medical director at Brookhaven National Laboratories. And this was published in Synapse journal. On the top, these are positron emission tomographies, and on the top, what it's showing you is 3 different levels looking at the same brain. There's a normal control. And this is looking at metabolic activity. Metabolic activity, you can see higher yellow and red is higher metabolic activity. Well, the next panel is a cocaine abuser who's been clean for 10 days after his last cocaine. You know, it's very different than the normal control. I mean, the overall, and think about this, the overall metabolic activity of this person's brain is incredibly diminished. That's a very important change. And this is the same individual 100 days after his last cocaine. And you can see that it's starting to come back. But I tell you, this is a long-lasting and a fundamental change. We also see it in other aspects, other parts, actually every part of the dopaminergic system is impacted by drugs of abuse. The effects of cocaine. Again, this is also in Synapse from Norm Volkov's laboratory. This is looking at dopamine receptors in the brain. And we have here a normal control, and red and yellow or more. This is a cocaine abuser 1 month after his last cocaine, dramatically different than the normal control. And then this is that same person 4 months. And you can see that it's starting to look a little bit more like that and coming back. Again, this is a long-lasting and fundamental change for a basic neurotransmitter systems that are responsible for so many things in your body, but especially for your reinforcing and reward and what things you find pleasurable. So prolonged drug use changes the brain in fundamental and long-lasting ways. As we see, drug use can lead to structural and functional changes. And, you know, I would show you more data, don't have time today, but really this has led me and many others to understand fundamentally that addiction is a brain disease because the brain changes. It's true that what actually happens is that the circuits, brain circuits and the motivational priorities are usurped by drugs of abuse. And in fact, it's really, and we have evidence, and we can show you, that the circuits have been rewired because they don't no longer respond to the same pleasurable things. If you're a drug addict, you don't get the same kind of buzz off of things like food and sex as you do off of drugs. So the cues and the priorities have changed, and those systems have adapted to react to drug instead of other natural reinforcers. So addiction is the quintessential biobehavioral disorder, which means the biology and the behavior and are so intertwined that you can't separate them, and that's what makes it complex, and that's what makes, if it was just a biological issue and we could give people a pill, that would be great, but it's not. It's more than that, although medications are very important, and we've come a long way, especially in the field of opiate addiction, and I mentioned that briefly. Treating a biobehavioral disorder must go beyond fixing the chemistry. You need to address the biology, the behavior, and the social context. So this is a very complex biobehavioral disorder, and Marcia, you pointed that out perfectly. We need to treat the whole person. And how do we do that? Well, the Lexis model of the kind of treatment we should be giving everybody who suffers from addiction are outlined here. In the center in the red are the core principles of appropriate treatment: pharmacotherapy, intake assessment, treatment plans, abstinence-based, group counseling, urine monitoring, case management, continuing care. But somebody who's become addicted and all of their motivation now is driven by drugs, they need jobs, they need family help, they need childcare, they need medical help, mental health, vocational training, education, legal. Their whole lives have changed. And so they need that kind of help to put them back whole. And that's why we have to treat the whole person. So we've made a mistake in this country for many years adopting the acute care model. This is the acute care model where somebody's a substance abuser and they go into treatment, and then we have a non-substance abuser. Well, that's not how you treat chronic relapsing diseases. It doesn't work that way. But that's what we want. We want to put a cast on it, your broken leg, and 10 weeks later it's healed, and go, and what's wrong with you? You know, we had you got cured. No, that's acute care model. Detox is not treatment. And I am got to emphasize that to everyone. I'm probably preaching to the choir because most of you know, but detox is just the beginning of treatment. And so we need to adopt in this country, and we have been doing it, is a continuing care model. where somebody gets screened or somebody is identified through some mechanism to have a substance abuse problem or an addiction. They seek specialty care, but then they need to be followed just like any other person with chronic relapsing disease. People with diabetes just don't go in and see their physician and then go to an endocrinologist and then never see anybody again. There are always checks on people. Same thing with hypertension and with asthma. And in fact, we've made a mistake in this country by, only 5 minutes. By even people in doing treatment research like myself have made a mistake. Now, this is a hypothetical pharmaceutical company medication. They start off with their clinical trial and they measure, let's say, your hemoglobin A1C, and it's at an 8. And that's just some, that is a measure, but it's arbitrary in this particular slide. Then they give them the medication, and it goes down to 2. I think you die if your hemoglobin A1C is 2. But for the sake of purposes, it improves dramatically. And then they go off the medication, and it goes back up. What does that company say? Oh my God, this is a $10 billion a year medication. Let's get it to FDA. We're going to make a lot of money. So what have we traditionally done in drug abuse, however? Drug abuse is high when somebody goes into, is identified, they go into treatment, their drug use goes down usually when they're in treatment. They leave treatment and their drug use goes back up. And what do we say? Didn't work, didn't work, didn't work. I used to go to Capitol Hill and try to sell this shtick to these, the 20-year-old kids who run the country in the Congress. And their eyes would roll up in the back of their heads, when you try to tell them that this does work. Because why? Because everybody knows somebody that it didn't work for once, or maybe twice, or maybe 3 times. And that's what a chronic disease is. You have to keep at it, and you have to treat it, not on an acute, but as a chronic relapsing disease. Tom McClellan published this in the Journal of the American Medical Association in 2000, comparing the relapse rates of drug abuse and dependence, of type 1 diabetes, 30 to 50%, of hypertension, relapse rate is 50 to 70%, asthma, 50 to 70%. And so this tells you that it's, we got a pretty good relapse rate compared to hypertension and asthma. And so it begs the question then. So if we treat a diabetic and the symptoms don't subside, what would a physician do? Would he increase the dose of the medication? Would he maybe change the medication? Would he change the treatment approach altogether? Would he fail to provide ongoing treatment for the diabetic? No. The answer to these questions is no, but still in 2015, about 10% of the drug treatment programs throw people out of treatment for dirty urine. That's unconscionable if you're treating a chronic relapsing disease. And so we wouldn't do that with a diabetic, and we wouldn't do that with a hypertensive. But we do do it with addiction. So again, back to the continuing care model, I can't emphasize enough. Primary care of some sort, identification and screening, specialty care, and the continuity of care. And we also need to keep our eye on the targets that we want. Abstinence is always a gold standard for people who are addicted to drugs. But we also have to consider functionality. People need to become functional, and how they get there, everybody's path is different. So functionality in their family, their work, and their community. I want people who are addicted to drugs to not take drugs, to function, to get jobs, and to pay into Social Security so that I can collect that in about 6 years. And then everybody wants reduced criminal behavior. That improves all of our lives and all of our communities. So advances in science have revolutionized our fundamental views of drug abuse and addiction. I think treatment is the key, and working in the criminal justice system, very much the key. Because what it does is it reduces crime, which we all want. It saves money. So I'm going to go back. And it improves lives. And if you just want to reduce crime and save money, okay. If you don't care about improving lives, I don't care. I'll dance with those who brought me, as long as we treat the people that we need to take care of, who have suffered from the disease of addiction. So in wrap-up, advances in science have brought us to a new understanding of drug abuse and addiction, and this knowledge is allowing us to develop more targeted strategies, prevention, and treatment. In opiate addiction, we're so fortunate to have, 5 or 6 FDA-approved medications to treat opiate addiction. We have methadone, which has been around for 50 years. We have buprenorphine. We have buprenorphine with naloxone. And actually, at NIDA, I was part of the team that helped develop that with the pharmaceutical company that sells that. And then we have naltrexone, which is a blocker. And the newest member on the market is a long-acting injectable naltrexone, which is called Vivitrol, and it lasts for about 30 days. I'm actually doing a study at the Metropolitan Detention Center. I'm trying to do a study. We're about to start doing injection of Vivitrol pre-release for people who suffer from opiate use disorder. And so we're very fortunate. I get a lot of pushback on the methadone stuff. I just got to tell you, I do a lot of training of judges, and man, I hear this more than once. I don't believe in methadone. And I, of course, risk spending a night in jail many times by saying, what do you mean you don't believe in it? Is it a unicorn? Is that what you mean? I said, there are 12,000 journal articles and peer-reviewed journals published on the usefulness of methadone in the treatment of opiate addiction for 50 years. And so I don't really usually get very good answers to that. So where do we need to go from here? Well, we need to advance evidence-based treatments. One size doesn't fit all. Everybody treatment has to be tailored. And it's only in doing this will we end the horrible stigma and discrimination, I mean discrimination, for people who suffer from this disease. They may have done it to themselves, but guess what? People do it to themselves to get diabetes or to get asthma or hypertension or cancer, lung cancer. And all of these things have behavioral components. So once somebody's addicted, we have to help reduce the stigma and discrimination. A new day is here in the field of addictions because of things like the Affordable Care Act and the Parity Act. The Affordable Care Act makes behavioral health, mental health, and substance abuse an essential health benefit for all insurance plans, all health coverage. This is from my portal in Santa Fe in the morning. So anybody from New Mexico always has to show the beauty of the state. So a new day is here in the field of addiction. We can have a major impact on the lives of New Mexicans. Thank you very much for your attention.